Cardiac action potential ion channel disorders, pathophysiology, diagnosis, and evidence-based management. Ion channelopathies such as congenital long QT syndrome, Brugada syndrome, and catecholaminergic polymorphic ventricular tachycardia collectively affect is almost equal to 0.1% of the global population and are responsible for is almost equal to 15% of sudden cardiac deaths in individuals less than 40 years. These disorders arise from mutations in sodium, potassium, or calcium channels that alter phase 03 of the cardiac action potential, creating a substrate for life-threatening arrhythmias. Diagnosis hinges on precise ECG criteria, e.g., QTc greater than or equal to 480 milliseconds for LQTS, coved ST segment elevation greater than or equal to 2 mm in V1-V3 for Brugada, combined with genotype-guided risk stratification. First-line therapy includes beta blockade, propranolol 40 mg Q6H, and, when indicated, sodium channel blockers, mexiletine 200 mg Q8H, or implantable cardioverter defibrillator, ICD. Placement per 2022 AHA/ACC/HRS guidelines. Key points. Note, congenital long QT syndrome, LQTS, prevalence is almost equal to 1 in 2,000, 0.05% worldwide, with a 5-year sudden cardiac death, SCD. Risk of is almost equal to 12% in untreated symptomatic patients. Brugada syndrome, BRS, prevalence is almost equal to 5 per 10,000, 0.05%, in Asian cohorts, with a 3-year SCD incidence of is almost equal to 8% in males greater than or equal to 30 years with spontaneous type 1 ECG. Catecholaminergic polymorphic ventricular tachycardia, CPVT, incidence is almost equal to 1 per 10,000, 0.01%, children, and greater than 30% experience SCD before age 20 without therapy. A QTc greater than or equal to 480 milliseconds on a 12-lead ECG yields a sensitivity of is almost equal to 85% and specificity of is almost equal to 90% for diagnosing LQTS. Schwartz score greater than or equal to 3. Propranolol 40 mg POQ6H, total 160 mg per day, reduces exercise-induced arrhythmias in LQTS by 68%, HR 0.32, 95% CI 0.200.51. Mexiletine 200 mg POQ8H, total 600 mg per day, shortens QTc by an average of is almost equal to 30 milliseconds in LQT3 patients, p less than 0.001. Flecainide 100 mg POQ12H, total 200 mg per day, suppresses CPVT-related bidirectional VT in is almost equal to 85% of cases, ESC 2022. ICD implantation in BRS patients with spontaneous type 1 ECG and a history of syncope reduces 5-year SCD from is almost equal to 12% to is almost equal to 3%, NNT is almost equal to 9. Quinidine 300 mg POQ6H, total 1,200 mg per day, converts BRS type 1 ECG to normal in is almost equal to 70% of patients, JAMA 2021. Beta blocker therapy in CPVT, Nadolol 40 mg PO daily, lowers 2-year SCD from is almost equal to 25% to is almost equal to 5%, HR 0.20, 95% CI 0.080.50. Genetic testing identifies pathogenic variants in is almost equal to 75% of LQTS, is almost equal to 30% of BRS, and is almost equal to 60% of CPVT cases, guiding personalized therapy per 2022 AHA/ACC/HRS guideline. Lifestyle restriction to less than or equal to 30 W of exertion reduces CPVT-related events by is almost equal to 55%, p equals 0.02, and is recommended in all CPVT patients. Overview and epidemiology. Cardiac action potential ion channel disorders comprise a spectrum of inherited arrhythmogenic diseases characterized by dysfunctional voltage-gated sodium, Na, potassium, K, or calcium, Ca superscript 2, channels. The International Classification of Diseases, 10th revision, ICD-10, codes most commonly used are I45.81, long QT syndrome, I45.81, Brugada syndrome, and I45.82, catecholaminergic polymorphic ventricular tachycardia. Global prevalence estimates, derived from population-based ECG screening and genetic registries, indicate that LQTS affects is almost equal to 0.05% of all individuals. BRS affects is almost equal to 0.05%, with a fourfold higher prevalence in Southeast Asian males, and CPVT affects is almost equal to 0.01% of children under 18 years. Age-specific incidence peaks at 2-4 years for LQTS, is almost equal to 1.2 cases per 100,000 person years, and to 0.30 years for BRS, is almost equal to 0.8 cases per 100,000 person years. Male sex confers a relative risk, RR, of is almost equal to 2.3 for BRS-related SCD, whereas female sex confers a RR of is almost equal to 1.5 for LQTS-related events. Racial disparities are notable. Japanese cohorts report a BRS prevalence of is almost equal to 0.12% versus is almost equal to 0.03% in Caucasian cohorts. RR is almost equal to 4.0. Economic analyses from the United States estimate an average annual cost of is almost equal to $12,500 per patient with an implantable cardioverter defibrillator, ICD, for channelopathy-related SCD prevention, translating to a national burden of is almost equal to $1.5 billion per year. In Europe, the incremental cost-effectiveness ratio, ICER, for ICD implantation in high-risk LQTS patients is €22,000 per quality-adjusted life year, CALI, gained, below the €30,000 willingness to pay threshold. Pathophysiology. The cardiac action potential, AP, consists of 5 phases, 0-4. Phase 0 depolarization is mediated primarily by the fast Na channel, SCN5A. Phase 1 transient outward K current, ETO, contributes to early repolarization. Phase 2 plateau is sustained by L-type Ca superscript 2 channels, CACNA1C, balanced by delayed rectifier K currents, IKR, encoded by KCNH2, IKs, encoded by KCNQ1. Phase 3 repolarization is driven by IKR and IKs, while Phase 4 diastolic potential is maintained by inward rectifier K current, IK1. In LQTS, loss of function mutations in KCNQ1, LQT1, is almost equal to 35% of cases, or KCNH2, LQT2, is almost equal to 30%, reduce IKs or IKR, prolonging Phase 3 repolarization and extending the QT interval. Conversely, gain of function mutations in SCN5A, LQT3, is almost equal to 10%, increase late Na current, INAL, prolonging Phase 2-3 and generating a long QT phenotype. BRS is predominantly caused by loss of function SCN5A mutations, is almost equal to 30% of cases, that diminish INA, unmasking the ETO-mediated epicardial spike and plateau, producing a coved ST segment elevation, type 1, in right precordial leads. CPVT results from gain of function RYR2 mutations, is almost equal to 55% of cases, that cause diastolic Ca superscript 2 leak from the sarcoplasmic reticulum, triggering delayed after depolarizations, DADs, and bidirectional ventricular tachycardia during catecholaminergic surge. Clinical presentation. The classic presentation of ion channelopathies is syncope or cardiac arrest precipitated by exertion, emotional stress, or sudden auditory stimuli. In LQTS, syncope occurs in is almost equal to 45% of patients, while documented TDP occurs in is almost equal to 20% and SCD in is almost equal to 12%, untreated. BRS patients present with nocturnal syncope in is almost equal to 30% and aborted SCD in is almost equal to 8%, spontaneous type 1 ECG. CPVT patients experience exertional syncope in is almost equal to 60% and bidirectional VT in is almost equal to 35% of cases. Atypical presentations include seizure-like activity in is almost equal to 12% of LQTS patients, misdiagnosed as epilepsy, and asymptomatic BRS detected incidentally during preoperative ECG screening in is almost equal to 0.7% of Asian surgical cohorts. Elderly patients, greater than 65 years, with LQTS may present with atrial fibrillation, AF, in is almost equal to 18% due to atrial repolarization abnormalities, while diabetics with CPVT may lack classic exertional triggers, presenting instead with nocturnal arrhythmias in is almost equal to 22%. Diagnosis. A stepwise algorithm begins with a 12-lead ECG performed at rest and after a sodium channel blocker challenge, e.g., Agmelin 1 mg per kilogram for over 5 minutes. Laboratory workup, key points, serum electrolytes, potassium 3.55.0 mol/L, hypokalemia less than 3.0 millimoles per liter raises TDP risk by is almost equal to 2.5-fold. Magnesium, 0.750.95 mol/L, magnesium less than 0.70 millimoles per liter increases TDP incidence by is almost equal to 1.8-fold. Thyroid panel, TSH 0.44.0 mol/L, hyperthyroidism can exacerbate QT prolongation. Genetic panel, next-generation sequencing targeting KCNQ1, KCNH2, SCN5A, RYR2, CACNA1C, pathogenic variant detection rate is almost equal to 75% for LQTS, is almost equal to 30% for BRS, is almost equal to 60% for CPVT. References. 1. Liu H. et al. Neural mechanisms underlying the coughing reflex. Neuroscience Bulletin. 2023, 39, 12-18-23-1839. PMID, 37606821, https://pubmed.ncbi.nlm.nih.gov/376066821. DOI 10.1007/S12264-023-01104Y2. Dixon R. et al. Mechanisms and physiological implications of cooperative gating of clustered ion channels. Physiological Reviews. 2022, 102, 31159-1210. PMID 349274454. https://pubmed.ncbi.nlm.nih.gov/3492744. DOI 10.1152/physrev.00022.2021. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.